to have Dr. Steve Marks, who came all the way from uptown at Columbia, back to his old stomping ground. The topic of atrial fibrillation was chosen because it really comes full circle. Sinai was and has been and continues to be one of the leaders in diagnosis, management, treatment, and future directions in atrial fibrillation. Some of the people on our panel certainly have been in the forefront for many years. And this afternoon, we were privileged to hear a lecture on some of the new animal models by Dr. Marks. The topic is very interesting. I just want to let you know that we have in December, Dr. Januzzi is going to be our visiting professor. His topic is going to be on biomarkers in heart failure. And in January, we're privileged to have Dr. Scott Gottlieb, who is director of the FDA, who will be our visiting professor. This topic, new concepts in atrial fibrillation, was actually very difficult to put together as a single monograph, but our fellow Luke Murphy did it very successfully. He's going to give us a brief synopsis of the monograph. Luke?
Good afternoon, everyone, and thank you for attending this month's Controversies in Cardiology conference. Dr. Marks, thank you very much for visiting us. We were all very excited to welcome you back to Sinai, and it was an honor to be able to spend the day with you. Your talk earlier this afternoon provided fascinating insight into your important work in mice models and Afib. Thank you also to all of the panelists who agreed to be part of this afternoon's discussion. We're incredibly lucky to have such a distinguished experts gathered to teach us about such an important topic. And Dr. Fuster, as always, we are all very grateful to you for agreeing to moderate the panel. I'll start with a controversial statement. Atrial fibrillation is a real problem. Afib currently affects 33.5 million people globally. Some epidemiologists will tell you that if you're an adult greater than 55 years of age in this country, you'll have a 1 in 4 chance of developing Afib in your lifetime. Prevalence of Afib is increasing as the population ages, leading some to suggest an Afib epidemic. Well known is the 4 to 5-fold increase in risk of stroke with Afib. Epidemiologic studies also suggest a 3-fold increase in risk of heart failure, as well as associations with early cognitive impairment, dementia, decreased exercise tolerance, and worsened quality of life. If you were in the Framingham cohort and were seen to develop Afib, your risk of dying doubled. This is all to say that there is some urgency to develop a new care model to address Afib. There have been great strides, including strides taken by people in this room, toward defining therapies that prevent the complications of Afib. A comprehensive overview of anticoagulation and left atrial appendage closure in Afib would likely require at least a few afternoons worth of panel discussions, and the topic will not be the focus of this preamble. There have also been great strides in identifying and refining effective strategies for the prevention of Afib, both primary prevention and restoring and maintaining sinus rhythm when Afib does occur. Two areas in which some of the most impactful recent work has been done at first seem to be on opposite ends of the therapeutic spectrum for Afib. On the one hand, defining Afib risk factors and the effect of risk factor modification on Afib prevention, and on the other, advancing Afib catheter ablation technology. However, it is becoming increasingly clear that any rhythm strategy has to include a focus on aggressive risk factor modification, because, as others have noted, Afib should rarely be thought of as solely an electrical problem. Attention to the upstream drivers of Afib is likely as important as the choice of downstream therapies for rhythm control. And as the indications for catheter ablation expand, we will have to remain cognizant of the vital role of risk factor modification to ensure durable improvement in post-procedural outcomes. This year, the European Heart Rhythm Association released a position paper on the crucial importance of risk factor modification in treating AFib. The paper provided recommendations targeting specific risk factors, among them smoking, alcohol use, obesity and physical inactivity, OSA, hypertension, and diabetes. The authors also stressed that attention to risk factor modification should be a lifetime project and one that begins at a young age, even before overt cardiovascular risk factors are present. Obesity serves as a good model for a comorbidity that promotes AFib through myriad complex pathways, and one that we have successfully targeted to reduce AFib burden. Animal models of obesity show increased atrial conduction heterogeneity and increased atrial fibrosis. Obese animals have more episodes and greater cumulative burden of AFib. Some of the effect is thought to be mediated by the direct paracrine activity of epicardial fat, which is increased in the region of the posterior left atrium and is active in secreting hormones and pro-inflammatory mediators. Epicardial fat, as quantified on CT, was shown to correlate with prevalent human AFib in the Framingham offspring cohort, even after adjusting for other measures of obesity. Prospective studies of bariatric surgery cohorts in Sweden demonstrated decreased de novo AFib incidence with weight loss surgery, suggesting the power of weight loss as a primary prevention tactic in AFib. Other studies, including the Legacy study and the ARREST-AF trial, have shown that physician-directed weight loss interventions, alone or as part of a comprehensive risk factor reduction program, very effectively lead to increased freedom from AFib after catheter ablation or cardioversion. Some have advocated for an even more targeted approach directed at the proximate mechanisms of AFib generation, including atrial fibrosis, altered cellular calcium handling, altered ion channel function, and dysregulated autonomic nervous system function. These are presumed to be the final common pathways by which many of the prevalent cardiovascular risk factors are thought to promote AFib. There is some hope that there may be a pharmacologic target or a biomarker waiting to be discovered among these pathways. Given our knowledge of the often complex, multifactorial pathways by which AFib is generated, it is almost surprising that catheter ablation would be an effective tool to treat AFib. And yet, in the properly selected patient, it is. More evidence is mounting that catheter ablation decreases symptoms and decreases AFib burden. The publication of ATAC in 2016 and the presentation of the CASTLE-AF data at ESC in August suggests that in certain high-risk populations with AFib, especially in the population of patients with comorbid AFib and heart failure, catheter ablation may even improve heart outcomes like mortality. We are all awaiting publication of large-scale trials like the ongoing Cabana trial to clarify exactly how strong will be the mandate for catheter ablation in high-risk patients. Catheter ablation is becoming safer and more effective. New techniques to add on to the backbone of pulmonary vein isolation are being actively investigated. Contact force catheters and cryoablation have been shown to be viable alternatives to standard radiofrequency ablation. Ablation targets beyond the pulmonary veins are being actively investigated as well. To date, there have been mixed data, and the most recent guidelines suggest that more study is required to define the usefulness of these techniques. However, this robust research activity raises the exciting possibility that in the future, we will be able to pursue an ablation strategy personalized to the patient and his or her specific pathophysiology and risk profile. Over the next decade, AFib as a clinical entity will become more and more important, both in terms of sheer numbers and in terms of our understanding of the implications of the disease and the challenges of treating it. We will have to decide on an appropriate therapeutic model to confront this growing epidemic. Recent clinical and translational research suggests that an ideal approach to AFib treatment should include a strong focus on cardiovascular risk factor modification. It should encompass a mechanistic understanding of the drivers of AFib and the way that current therapeutics can modify the effects of these drivers. It should use imaging to help define the atrial and ventricular substrate in which AFib is occurring. And finally, guided by developing clinical research, should incorporate catheter ablation with the goal of reducing symptoms, improving quality of life, and improving mortality. Thank you.
Okay, thank you very much, Jonathan, for this presentation. This is a difficult subject, actually. Interestingly, there are 3 guidelines that evolved at the beginning of 2017, February, March. And what we are going to be talking today is already out of the guidelines. So the field is evolving so rapidly that it is difficult, but at the same time is exciting. Well, let's go first for an exciting man who is the visiting professor today, Stephen Marks. Many of you know him. Actually, very nice. He puts the date of birth, August 9, 1964. He's a young guy. So, yeah. He was born in New York City. He had magna cum laude in biology and sociology before medical school, and in medical school he obtained his degree in Albany Medical College. And then in June of 1988, he became a research fellow at Johns Hopkins in the Department of Biomedical Engineering. Then he moved to Rochester, New York, where he had his internship and residency at the Strong Memorial. And then he came to Sinai, where he was cardiology fellow between 1992 and 1994, and in 1995 he entered our clinical electrophysiology fellowship. Then in 1996 he became clinical assistant here at Mount Sinai. In 1997, assistant physician at New York Presbyterian. And then he moved into assistant professor, associate professor, and at the present time, he's professor of medicine and pharmacology with tenure at the Columbia University College of Physicians and Surgeons, and then he's the director of the cardiovascular fellowship program. Well, very accomplished. First of all, he has a large number of awards that go back to when he was in college. And then he moved into, in the early 1990s, American College of Cardiology Merck Fellow, Stable Memorial Heart Failure Research Award, American Heart Association, CATS Award finalist of the American Heart. And then more recently, Ewing Teaching Award, Department of Medicine at Columbia. This was 2016. Columbia University Medical Center Mentor of the Year, 2016. Louis Katz Cardiovascular Prize at Columbia, 2010, and so forth. So he really is a person that we could say of great value. Continuation of his CV. Here's the editorial board of Circulation, Arrhythmias, and Electrophysiology, of course, of the senior editor and basic clinical research at the Journal of the American College of Cardiology. And then he's also a board consulting editor of the Journal of Clinical Investigation. Now, during his early career, he already had a number of awards and grants that made him to eventually move into NHLBI, and amazing, he has 10 grants, has had 10 grants for the National Institute of Health, which is amazing. He became the Cardiovascular Fellowship Program Director in 2008, and he actually has been the mentor of many, many investigators with a great success. Now, obviously, he is a person who has contributed a lot to the field. He has close to 50 papers in the highest impact factor basic science journals. First paper of interest in 1991, outward currents in isolated ventral cochlear nuclear neurons. I don't know what in the world were you doing, But it's nice that you finally went into the heart. You contributed significantly with the group here with the rapamycin development, the fast drug eluting stent. And he has worked on the ion channels for two main objectives: to understand the electrical system and in a way also to understand the myocardial system. So very accomplished, and we feel very proud you were here as a fellow. And I must say, when he finished the fellowship program, I still remember that he came to see me what to do next. And he had finished electrophysiology, and I was the one who actually suggested to go to Columbia, because there were the right people there and was the best for his career. And I think this is very important, that we really work with the fellows for the best of their future, regardless of whether we would like the fellow to stay here or not. Well, anyway, thank you very much for coming today, and let me give you this plaque in the name of Mount Sinai to you for outstanding teaching, wisdom, and expertise as the Nandi Sharma Visiting Professor and the Simon Duck Memorial Lecturer. And this is the check, not very substantial, but it means a lot.
Thank you very much.
Nice to see
Thank you. Thank you very much.
Okay, so Stephen, if you can, maybe in the middle, yeah. And then Laurie Croft, Noel Langan, Jeffrey Mechanic, Vivek Reddy, and Jonathan. This subject, for those who see medicine in a superficial way, is simple. For those that are more curious, is extremely complex. In fact, I must tell you that of all these sessions that I have been moderating, this to me has been the most difficult one. Despite that on the first door, I have been working in this field for a while. I was involved with the first guidelines, but the fact of the matter is moving so rapidly, and today we can testify about what really happened in the last few months, and it's amazing if you really want to know and be up to date. So we will start in a very simple way. Few figures Jonathan actually mentioned. 33 million people have atrial fibrillation. But I always have a question. If you have somebody in front of you who is age 80, what is the chance of that person to be in atrial fibrillation? And you divide the decade 8 by 2, is 4%. All right? This is important, because the other question is, if that person is not on anticoagulants, what is the chance to have a stroke? Is the decade 8% per year? I say this because many times we talk to patients in a very abstract way, but the patients, what they capture are numbers, and this is why I think it's important to at least remember these figures. Is the figure of the decade divided by 2, and the figure of the decade in terms of the incidence of atrial fibrillation, and the figure of the decade 8, in this case, of 80 years, is 8% per year evidence of thromboembolism. Now, this problem with atrial fibrillation, as you know, has a number of implications. Of course, the most dramatic one is a stroke. But, you know, atrial fibrillation, as we will see today, is the tip of an iceberg. It's associated with many things. So it's not even to say it's causing heart failure. Heart failure is associated with atrial fibrillation. Cognitive decline, quality of life, and so forth. So the question is, in terms of cost, people like to talk about it, but it's basically 10% of the total cost of medicine in the United States. Is actually about $30 billion a year to treat atrial fibrillation, and it's $300 billion a year the cost of medicine in this country. So it's about 10% has to do with atrial fibrillation. Well, many of you will be thinking this is very boring, but just wait because there are many things we have to discuss today. In terms of management, things have advanced tremendously. We have more and more atrial fibrillation since people is getting older with more risk factors, but certainly great advances in three fields: in the fields of anticoagulation, in terms of the prevention of strokes, in the field of better quality of life, and this is management, particularly with catheter ablation, is certainly in the field of prevention, which is addressing the risk factors that we are talking about. So this is just an introduction. I have three pieces of introduction. The second piece of introduction just was published a week ago, and it's fascinating. It's the so-called the ABC pathway, an integrated approach to improve atrial fibrillation management. And basically, the atrial fibrillation better care pathway, which is ABC, has three items. Avoid the stroke, this is the A. The second, better symptom management, this is the B. And the C is cardiovascular and comorbidity risk reduction. I'm saying this because the discussion that we are going to have today really will be very much focused in these three aspects. Having said that, I want to mention the final study just published, the so-called IMPACT AF study. And this is a very interesting study that basically is based on the fact of a very aggressive education to the patients and to the doctors and the families involved with atrial fibrillation. And this was a study that was actually randomized. And just to make the long story short, it was a very significant impact in terms of how these patients were treated. For example, in terms of anticoagulation, from 68% at baseline, it went into over 80% at 1 year in the educated people, where those who they were told what to do, but without the educational process that was very involved, from 64 to 67%. What that means is that all of us can be educated. And here, part of the education were the physicians, interesting. But it's just to give an introduction to a field that is very important with issues that just took place. I'm going to divide the discussion today in four different aspects. The first one is etiology, but etiology at the more basic level. And then the second part will go into anticoagulation, the third part on the symptoms, as we presented a minute ago, and the fourth part in terms of what we know about the risk factors, the modification, and how we can prevent atrial fibrillation. And I'd like to start with something that Vivek has done well. Here is with Dr. Dukapati. It's a good editorial, actually. It's just very recent about a paper. And the title of the editorial is Catheter Ablation of Rotors for the Treatment of Atrial Fibrillation. And here, from the point of view of electrophysiology, one begins to understand the etiology of the disease, as complex as it is. Vivek, what you wrote is the following. Heidegger, who from France, was the one who understood that the initiation of few APCs and atrial fibrillation was in the pulmonary veins. And we are really talking about 1998. So we are talking about 20 years ago when the whole field evolved. So something happens somewhere which is near the pulmonary veins. Then what happened is, as the electrophysiologists got into the field, they began to see that were not only the pulmonary veins or around the pulmonary veins were even more separated in the antral regions, that such APCs and atrial fibrillation could actually evolve. And more eventually, and more recently, it seems it's all over the place, as we will be discussing, particularly as the atrial fibrillation from paroxysmal evolves into persistent and long-term persistent atrial fibrillation, which even the right atrium is also involved. Now, in this process, I want to ask you, Vivek, to start with, you guys may be quite, this is quite dramatic, the movement from a single point that was thought years ago into something that today most of the patients that present to us with persistent atrial fibrillation is all over the place, whether these are specific rotors or whether they are specific focus, whatever it is, but it becomes quite complicated.
So yeah, so it was in a lot of ways it was easy when we thought about just focal triggers. And initially we went after the focus, then we realized if you go after one focus, there's more than one focus. We ended up isolating the pulmonary veins, and that treated most patients with paroxysmal AFib. And you're really asking about persistent AFib. I think I can't overemphasize how messy the data is. And what I mean by that, it's not that the data is presented poorly. I think AFib, as you said, the number of papers that have been published is quite substantial. The work is being done by, very dedicated and really intelligent and whatever physicians. The problem is that our tools are not very good and in terms of accomplishing what we want to accomplish, and our ability to map the atrium is not very good. So you end up with two situations. One is when we isolate the pulmonary veins, we don't do as good of a job at getting durable isolation as we want. So to ask the very simple question of, is PV isolation enough for persistent AFib? The answer right now is we don't know. Meaning, let me rephrase the question. We know that PV isolation is enough for some percent of patients with persistent AFib, but we don't know what that number is because we can't accomplish durable PV isolation in persistent AFib. So at this point, I can't even tell you an answer to that question. Then you layer on top of that when we start doing additional ablation, whether it's ablation of complex fracturing electrograms or identification of rotors by whatever technology you're talking about, none of these approaches are very good. So I should rephrase that. None of these approaches are precise enough that we can just do 1 or 2 point location ablations. We end up doing a lot of ablation in any given patient. So you end up with this with a point where you do a bunch of different ablations. Some of it is probably relevant and some of which is probably irrelevant. And so it's very difficult to answer these questions. We require large numbers of patients to answer any question. None of us want to randomize. Let me rephrase that. It's difficult to do a study and keep the same technique over the course of the study because if it's not completed quick enough, our feeling of what's important evolves over time. So I think what I'm trying to tell you is that this is complicated. Our mapping tools are getting better, but we're still not to the point where I think we can say this is a rotor that is of relevance in a given patient.
Let me ask you, it seems to me there's a lot of literature coming out at this time that, for example, for the identifying all the different points that are firing, you use a cascade approach. And this is a catheter that really entails the whole atrial system. And then you have another one, which is an external burst with 250 electrodes. It appears to me that people are talking more and more about this. Are you using this? You believe on?
Yeah, there's more than just the two, unfortunately or fortunately. So there's the two that you refer to. One is a multi-electrode basket catheter that sits in the heart to try to identify rotor activity. The major limitation of that is it's hard for the catheter to touch that much of the atrium. So you end up with the catheter not touching in some locations, touching in some locations. The data is unclear. One group has published heavily with good outcomes, but has not been reproduced by others. The other mapping system is the external system where you put, it's like an EKG, except you have 256 electrodes on the patient's surface, and it tries to interpolate what's happening on the patient's surface. Hasegawa's group is the one that really has pushed this forward over the past couple of years. The data, and their data is, it's interesting. None of it's randomized, none of it's definitive. Others have used this system with variable results. We have used the system with, it's plus minus. I think it's still something in evolution. There's another system that we're using where we try to use an internal mapping catheter to map around in the atrium. We're going to be presenting data on that soon, which I think is a little more promising. But the point is, none of these systems are that good. None of them identify, yes, this is the location, or these are the two locations, and when you get rid of it, the AF terminates.
Final two questions, and we'll end bothering you until later. First, what is this approach where you're excluding the left atrial appendix? It appears a big deal.
For a rhythm perspective, yeah. So one of the interesting hypotheses is the left atrial appendage. There were certainly case reports published where there was a focus from within the appendage that was causing fibrillation. And in patients who had undergone multiple previous procedures, it was reported that the appendage may be important as a harbor of the trigger for Afib, so from a rhythm perspective. More recently, I guess about 2 years ago now, there was a study called the BELIEF trial. It was a prospective randomized trial which took patients with long-standing persistent Afib, and that's critical, long-standing persistent Afib patients, and randomized them to an Afib ablation strategy that involved lots of stuff versus all of that plus electrical isolation of the left atrial appendage. Again, this is not for stroke prevention. In fact, it probably worsens stroke, but it's for from rhythm control perspective. And that prospective randomized trial was positive for electrical isolation of the appendage, suggesting that in long-standing AF patients, isolation of the appendage is favorable. Now, following that up, there's a larger randomized trial, 600-patient trial called the AMAZE trial, which we are participating in, which is looking, again, at the same question, but the approach to electrical isolation is actually tying off the appendage. So it's both a structural as well as an electrical approach using a lariat catheter. It's a percutaneous pericardial catheter to tie off the appendage. So half the patients in this group undergo AF ablation, the other half undergo AF ablation plus electrical ligation / isolation of the appendage. That's a study that's looking at both persistent and long-standing persistence. So here, it's both using a slightly different approach and trying to extend that to the persistent population, not just long-standing. So we'll have to see what the data looks like. I think there are about 200 patients in out of a 600-patient study, so it's going to be a while before we have that data.
Okay, Stephen, basically what we have been talking is about different places that are firing, particularly as the process of atrial fibrillation moves from paroxysmal into persistent. But here is the question, what is the problem? Is the problem a cardiomyopathy leading to the atrial fibrillation? Or is the atrial fibrillation with all the ion channels that you have been working on leading to fibrotic phenomena and then being a consequence? The only reason I'm mentioning this is because when we talk about thromboembolism has very little to do with atrial fibrillation. It has to do how the atrium is working and maybe in sinus rhythm. And I think this is something very new, which really puts the cardiomyopathic aspect in front of us rather than the electrical system.
So I think it's both, unfortunately. I think that atrial fibrillation, first, we all learned that atrial fibrillation begets atrial fibrillation. So the longer you're in atrial fibrillation, the more likely you are to remain in atrial fibrillation. That's probably due to remodeling within the atrium, including remodeling of the ion channels within the atrium. I think it's pretty clear. The data is probably reasonably good, showing that there's remodeling of ion channels and there's changes in the action potential duration of the atrial myocytes as atrial fibrillation continues. Some of that might be due to the rate of the heart rate. There's also obviously an atrial cardiomyopathy that's probably begetting the process to begin with, and that is going to be due to many factors, including left atrial enlargement, fibrosis, and heterogeneity within the atrium. And that heterogeneity within the atrium could be due to fibrosis. As I showed earlier today, it could be due to changes in the action potential duration. But there could be also changes in conduction velocity that could lead to the heterogeneity as well. A complex occurrences, many things going on within the atrium leading to atrial fibrillation. But as we know, the longer you're in atrial fibrillation, the more likely you are to stay in atrial fibrillation.
The question is very important, Laurie Croft. It's very important because imaging technology now is discovering, certainly we were talking before, the University of Utah is doing a lot of MRI in patients with atrial fibrillation. What they are finding is not only a close relationship, that's what they say, between the degree of fibrosis in the atria and the incidence of atrial fibrillation, but even they can predict whether the ablation is going to be successful or not. That's one aspect. The other aspect is you as echocardiographer, and maybe using other modalities like CT, you can look at a left atrial appendix in normal sinus rhythm, and this can throw a clot in front of you. And I like to get into this because it seems to me that imaging is beginning to give us a completely different picture of what we had before. Before we thought atrial fibrillation is the cause of everything, and now we are thinking it's the consequence of everything.
So first addressing the fibrotic or the atrial cardiomyopathy or fibrotic cardiomyopathy, out of Utah, there's a group that's done a multi-center study looking at the amount of fibrosis, and they correlated fibrotic changes of the left atrium to the risk of, after an ablation, having your Afib come back. And they have a whole scoring system than they did at the Utah 1 through 4. And basically, the lowest number means the lowest amount of fibrosis. And those people, after they underwent catheter ablation, actually did quite well and did not have a reoccurrence of their atrial fibrillation. They also can kind of predict the Afib burden. There's the same group has looked at how often, if they have more delayed enhancement of their left atrium, they have a higher risk of having persistent atrial fibrillation. So when you talk about atrial cardiomyopathies and fibrotic cardiomyopathies, obviously MRI is a way of telling that. Prior to that, I guess we focused a lot on the left atrial appendage, the way it looked, how it functioned. It had good contractile velocities. And so when we do these TEs, when people come in for a source of stroke or things like that, and we look at the atrial appendage, there's certain characteristics we look at. If they have a low, there may not be a clot there, but they may have a low velocity, which may portend a poor prognosis and a risk of stroke. As we know that even if you look at the left atrial appendage, there's no kind of temporal relationship. You can have AFib, a year afterwards or 30 days or whenever. So we look at the left atrial appendage to look at the way it's formed. If it has multiple lobes. If it has multiple lobes, you're at a higher risk than if not. If you have spontaneous echo contrast, looking at whether there's smoke in the left atrial appendage, that could have an incidence of having a CVA. And finally, the newest imaging modalities we use is there's a lot of literature looking at the deformation of the left atrium using speckle tracking or using what we call strain and strain rate. And there's a bunch of literature looking at whether or not the cardiomyopathy of the atria can be found out using this software called strain or speckle tracking. And that's a brand new it's an old technology, but it's brand new looking at the left atrium. And just recently there have been papers published looking at what the norms are. And so that's an exciting new field coming forward if you want to think of it as like a systemic disease or a disease of the atrium.
Well, there are 3 studies, and I want to mention the ENGAGE AF, the ASSERT study, and the IMPACT study. All the studies showing cases with embolism that had normal sinus rhythm. And the question these studies brought up is whether or not imaging technology should be used in all patients that have had some episode of atrial fibrillation and really assess what you are talking about, the velocity and so forth. But there are 2 or 3 papers recently which are interesting, and that is to look at the electrocardiogram. And that is, you have a patient who have had atrial fibrillation and the P wave is very minute. These patients are the ones who can embolize. And again, there are correlations being made. I say this because this is an issue that is very important about anticoagulation, and that is, of all the patients who are anticoagulated, there is a 65%, 70% success in preventing thromboembolism. But there's a significant number of patients that you do not prevent it. And these patients may be on sinus rhythm. So this is why the issue is quite important and significant to be taken into account. Well, having said all of this, I think the question that I would like to address now is what happened with the first topic, anticoagulants. You all know what we are talking about, but it just came an interesting paper from the European Heart Journal that they have 13 questions of what anticoagulants to use and why. And what is interesting, this paper was written in March of 2017, and now in half of the questions, things have already changed. And this is what I would like to perhaps to go into the details. Okay, Noel, here we start. Question number 1 is patients with a stable coronary artery disease or peripheral arterial disease. And patients with percutaneous coronary intervention, what kind of therapy would you use? The patient has atrial fibrillation, and then he has peripheral vascular disease, underwent stenting, or the patient actually has coronary disease, as I mentioned. And as it was written here, the approach to such patients, you give an anticoagulant for atrial fibrillation, and then you give clopidogrel and aspirin or dual antiplatelet therapy, and this is March of 2017. Would you do this today?
It's kind of interesting to me because very often, as we are consultants, we actually will call the cardiologist to have them participate in that decision, to be polite, and we have answers all over the map, which is interesting. But obviously, in the last year, we're getting more clear ideas that no, we should not do all three. We have some conflicting data over whether we should lower the Xarelto dose or not also, and so that's been...
Well, the Pioneer AF study, nothing is definitive, but certainly what they saw is that two of these agents, a platelet inhibitor and rivaroxaban, together, they don't increase the bleeding and they prevent significantly thromboembolism.
Right, we've had some interesting cases where the NOAC was, or the DOAC was changed because they wanted to go to Xarelto because that's the data we have. And, you know, that's a kind of interesting phenomenon too. Somebody who's already done well on a Eliquis, let's say, they come and get a cath and then somebody switches them
What
over
I
to
don't
Xarelto.
understand,
I can understand that, but it's an interesting phenomenon.
Jonathan, do you understand that one of the arms had rivaroxaban only 2.5 milligrams twice daily? Remember that we give rivaroxaban 15 milligrams, 20 milligrams daily, and the other was the platelet inhibitor. How do you think this work? Because for the atrial fibrillation, we never give so low dose. Tell me, what do you think?
Yeah, it's a very good question. You wonder if there's some kind of subclinical systemic effect of the lower dose, or I really don't think I could speculate.
It's like a low dose of rivaroxaban does something good to the clopidogrel, or the opposite, because otherwise it's difficult to understand, but the data is pretty impressive.
Which is also interesting because with Coumadin, that didn't pan out at all, as you remember.
Coumadin didn't work, you know that, yeah. So question number 2.
But let me
Yes.
just interject, though. I mean, I agree with everything you said and the concerns raised. Having said that, BID dosing is a different pharmacokinetics.
That's interesting.
You know, and
Good point.
you do get a different sort of trough than with single dose where it does this, right? So I'm only bringing this up because at least when I talk to people, John Halpern was here, but at least when I talk to people who are really dealing with the pharmacokinetics of this, they really do believe it is because of an anticoagulant effect as opposed to some other anti-blah, blah, blah effect that, you know, that
I think it's a good point, the pharmacokinetics. Question, yeah.
Also the philosophy of why Eliquis is doing so well, because they BID'd from the beginning.
Okay, question number 2. What do you use for cardioversion? The data is obvious today. You can use just right away the new oral anticoagulant without having to go to the warfarin. I don't think it's necessary that we go into this. Question number 3, valvular heart disease or a bioprosthetic valve. And what do you do? Stephen, what would you do? No mechanical valve. Those patients, you know, we use anticoagulants. But what would you do on this one?
I think that you more or less have to use Coumadin. Coumadin is the go-to agent for people with mechanical valves.
Well, the issue that why I'm making this comment is because since this paper is the Engage AF TIMI48 trial, which saying that the use of warfarin is the same as the use of endoxaban. This is just recent. So for the first time in valvular heart disease, we can begin to use a new oral anticoagulant without having to go into warfarin on patients who are on atrial fibrillation. So, question number 4. I'm going to pass by. The question number 4, patients with a single stroke risk factor, CHADS-BASC score of 1 in males and 2 in females. Jonathan, what do you think? Would you use an anticoagulant here? What would you do?
so I can give the kind of easy answer that you always have to be patient-centered when you make these decisions and discuss with the patients what their, preference for risks and benefits are. At least, from what I've seen clinical practice here in the last, 5 months or so, I think if we think someone will tolerate an anticoagulant, and they are sort of on board, we sort of would tend to start them on one of the NOACs, but again, it has to be a patient-centered discussion.
Well, as you know, basically the Europeans are completely different than the Americans. In Europe, the whole issue is who doesn't need anticoagulants, and they go after. And if they see grade 1, as I mentioned, or 2 for women, they put them on anticoagulants based on guidelines. In the United States, it's more these patients going to aspirin. This has been a big debate, but basically, it is now the guideline that just came out is between Americans and Europeans, and the tendency has been to move already into anticoagulation when there is a score of 1 in males or 2 in females. So I think that's is an interesting movement on that regard. So the next question that we have, let me just see, very interesting. Here they say atrial flutter, atrial fibrillation, episodes, whatever it is, you put the patient on anticoagulants, there is no difference. All the studies now are beginning to show the difference when people really look at that. There's very little question that the incidence of thromboembolism in atrial fibrillation is much less in paroxysmal than in persistent or permanent. Is this your impression, Vivek?
Yeah, I mean, now that we have large amounts of data and good data sets, I mean, it's pretty clear that paroxysmal patients have less AF recurrence. In fact, in some of the big AF ablation stroke trials that, well, the 2 that are going to be hopefully presented in the next couple of years, if there's the mechanism of any mortality benefit will likely be driven by 2 things. One is Afib and heart failure, which is a bad thing, and the second would likely be decreased burden of AF, which will probably translate to decreased stroke. So we'll see what happens.
The other issue is the patient has atrial fibrillation, is treated with antithrombotics, and has a stroke. What do you do? Do you do thrombolytic therapy while the patient is on anticoagulants for the atrial fibrillation? Do you use anticoagulants if you use the proximal thrombectomy approach, mechanical approach? Well, the data is beginning to evolve. And certainly you cannot do thrombolysis on a patient who is on anticoagulants for atrial fibrillation. You just cannot. The incidence of bleeding has been very high in the literature. And then the other possibility, which is thrombectomy, you can do it when the patient is on anticoagulant. Well, these are all issues, and there are a number of more that I think are of interest, but what is fascinating is how things are changing. Now, for example, gastrointestinal bleeding. And you say, when you stop your anticoagulant, and what do you think, Stephen? The patient bleeds because of the anticoagulant, maybe an ulcer, maybe not. Do you think, when would you start the anticoagulant again, if you do? This is gastrointestinal.
I think partly it depends on how bad the bleed was and what the patient's risk factors are for bleeding again, whether it can be fixed or not, and to define what the risk is for stroke, what their CHA2DS2-VASc score is, what their risks are. I would tend to try to restart them on anticoagulation once things stabilize.
They say it's about a week, actually. Yeah. Very interesting. They do quite rapidly. Now comes the issue of renal function, which is quite interesting because it's paradoxical. Now, the patient has is on dialysis, basically. And the question is what you do. He's on dialysis and the patient is on atrial fibrillation. And what would you do? Would you give warfarin? Absolutely not. They bleed from the kidney and they get calcification and gets things worse. So, how the drugs are excreted, the new oral anticoagulants, so the one that is excreted less by the kidney is apixaban. So the point is, the drug that is beginning to evolve is actually apixaban at a low dose of 2.5 milligrams twice a day. But what about if you have heparin-induced thrombocytopenia, which really kills the kidney? And the patient has been on heparin because of atrial fibrillation and so forth. And here is quite interesting. Since apixaban doesn't reach the kidney, you don't give it. You give dabigatran because you need something that is helpful in the kidney level. I'm just saying these are issues that are quite of interest, which really has to do with the pharmacodynamics of all these issues. Well, having said that, there's actually a number of questions, and that is how you deal with the elderly and so forth. But I'd rather like to move into the issue of left atrial appendix closure, because you do it because of bleeding. And here, Vivek, I have a problem. You have an article, just a moment, you have an article and you talk about the PROTECT AF atrial fibrillation with the Watchman. And the patients actually did well. Then the FDA approves the thing and they do much better. Do you believe so? Do you think the data is well captured? That's number one.
Oh, okay. So, yeah, so there's two trials, PROTECT and PREVAIL. The PROTECT trial was quite positive. The PREVAIL trial was not as well positive. In fact, it was arguably negative. Parts of it were. When we looked at the combined data, we see equivalent stroke reduction, better hemorrhagic stroke reduction, less mortality, overall mortality, and cardiovascular mortality. So, and this is data out to 5 years, randomized data out to 5 years, which is pretty strong. There's not much randomized data out to 5 years. But having said that, the data by itself, I think, is buttressed by additional pieces of data that are coming out. There's surgical data that's coming out that's, again, not randomized, but comparative surgical data from the STS database that hasn't been published yet, but John Passini presented this at ACC late breaking last year, looking at patients who underwent surgical closure versus non-surgical closure as a concomitant procedure. And those patients who underwent surgical closure had a subsequent lower thromboembolic rate compared to those that didn't, as well as lower mortality. There's that data, as well as there's several different large databases, including over 1,000 patients, using different types of percutaneous devices, non-randomized, but all of them showing low ischemic stroke rates in the subsequent year after implantation. So I think that you have randomized data that shows equivalent stroke rates to warfarin. You have non-randomized data with large data sets from sort of real-world populations. And then, by the way, next year, hopefully at ACC, we'll see data from the NCDR registry, which is, again, going to be non-randomized, but it'll be a very large data set. So, yes, I think it's strong enough.
I am bothered by the data on thromboembolism. When you have all the studies together, the randomized studies, it's 2.7% with the Watchman per year, 100 patients. And with the other, the ACP one is 3.2. And then the incidence of bleeding is 2.3 per 100 patient years and 2.1 per 100 patient. So I want to understand where these clots come from the device, and where the bleeding comes from. This is a big issue.
No, absolutely. So first of all, again, some of the numbers you threw out, I'm not 100% sure of what those numbers are, but I'll accept the fact, because I think it's true, that the ischemic stroke reduction relative to warfarin is not as good with appendage closure. But that's counterbalanced by a much better, I should say, much lower rate of hemorrhagic stroke. So you have two different types of strokes. I just really want to point out, remember, when you're trying to prevent stroke, you're trying to prevent stroke without causing stroke. And that's the confounding fact of using anticoagulants in patients. You're going to prevent stroke by decreasing ischemic stroke, but it's going to be dialed back by hemorrhagic stroke. The advantage with appendage closure is you don't have that peeling back of hemorrhagic stroke. But your decrease in ischemic stroke is not quite as good if you just look at ischemic stroke. But that's a comparative issue. Now, your specific question was, where do strokes occur in patients who have appendage closure? I think that's an important point. Some of it is going to be non-cardioembolic, so it'll be, whatever, hypertensive, et cetera. And some of it probably is, as you point out, or query, there are cases where the device is not healed over properly, and clots can propagate from the device itself and then embolize and cause a stroke. So I think that's an important issue, which is why we have to do TEs on these patients afterwards.
What about the bleeding?
Well, the bleeding, if you look at, again, the randomized data, once you get past the procedure-related bleeding that was really high in the early studies, I'm talking about pericardial tamponade, once you get past that, there's a 70% reduction in major bleeding. Okay, this is out to 5 years. But these are patients who got the device because they're already at high risk for bleeding. So if you only just look at the absolute risk of major bleeding, you're ignoring the fact that if you had put them on anticoagulant, it would have been a much worse bleeding. Now, you can say, well, I'm throwing all these numbers out, and, how do I know that you adjudicated the bleeding properly and all of that? And I think those are really good points. But the final issue is, if you simply count bodies at the end of the experience, and you say how many patients are left alive and how many are not, it's the variable that's least amenable to confounders, or to bias, I should say. And even there, you see a mortality benefit.
So the indications by the FDA is when there is significant bleeding, isn't this correct? And when they use anticoagulants, then you can use the device when there has been a bleeding. That's the main issue, isn't it?
That is the issue.
Yeah. Well, I think I'd like to move now into symptoms that are troublesome. We'll talk into the brain, Stephen, in a moment, because I know you're interested on, but I'd like to start with a question that came also in the questionnaire recently. Postoperative atrial fibrillation occurs in about 30% of people, any kind of operation, but particularly cardiac operation. The question is, what do you do with beta blockers, Jonathan? Do you start everybody in beta blocker? Or what do you do? Jonathan, you appear to be distracted. Just it's for you.
Yeah, I mean, I think on the consult service, we get called about this a lot. I think, there has been data in terms of preventing post-op AFib, especially in cardiac surgery patients. Routine use of colchicine can help prevent. But when you are faced with it, I think if you catch it early enough, I've seen people just try to, even chemically cardiovert within the first 24 hours. But then, if it's something that happens kind of farther out from the surgery, I think, and maybe you're not sure,
What about pre-op beta blockers?
Well, yeah, so I mean, that's maybe a slightly more complicated question. I know that, generally we don't like to...
Excuse me, it was complicated, but not now. There are 3 studies now showing the same thing. That is, you don't stop beta blockers to those who take them, but you don't put on beta blockers one has not taken them. That's basically the issue. It's coming from 3 recent studies. This is why this is a field that is changing so rapidly that is an interesting aspect. I'd like to get into the brain. Stephen, I know you do cognitive function in your mouse, but I think the data is actually quite striking. There are a number of studies now, a significant number of studies showing the microemboli in atrial fibrillation, lacunar lesions in the white matter of the brain. And whether the patients have been on anticoagulants or not, it's in both, which points out what we already talked a minute ago. But the most disturbing issue is there are 6 studies now showing not dementia, but certainly cognitive dysfunction in people with atrial fibrillation. And now there are 2 studies that correlate the cognitive dysfunction with the density of the lacunar lesions in the brain, whether the patient was on anticoagulants or not. So this is a huge issue, and I'd like you to comment on it.
I think it's a very complicated issue that is not simply due to emboli. It's due to systemic factors that are present in patients with atrial fibrillation. So it could be due to strokes or small microemboli, but some of it could also be due to changes in microcirculation, changes in systemic inflammatory markers, and multiple other factors that could be accounting for the neurocognitive dysfunction. I mean, we just don't know right now. I think that many of the studies recently, it's good to see that there are many studies showing that there is neurocognitive dysfunction, specifically the type of neurocognitive dysfunction such as executive functioning is altered, which is frontal lobe sort of lesions, although the mechanisms are still to be worked out.
The thing that is also frightening is the number of patients who have Alzheimer's and bleeding in the brain when they are on anticoagulants. So the question that has been brought up here is that if there is evidence of amyloid deposition in the vasculature of the brain, the patient should not be on anticoagulants. The problem is, how do you know? And this is a huge issue because people are getting older and older, and the issue of cognitive dysfunction is important. What I'm really bringing up in this discussion today is that we are in a field that is extremely complex. When you really go, it has to be individualized so much. But this has been an issue that is one paper after the other about the amyloid angiopathy and bleeding in patients who are on anticoagulants. Jonathan, do you have any comments?
No, I would love to hear more about that from the panel.
Yeah.
Let me just make one comment. This is basically just following up on what you were saying. The incidence of cerebral microbleeds is a really important issue. So there's more and more data that probably related to angiopathy, that there's microbleeds as patients get older. And particularly if you look at octogenarians, nonagenarians, et cetera, these cerebral microbleeds are important. And when you anticoagulate those patients, they have an extraordinarily high rate of it translating to intracerebral hemorrhage. So now the problem is, we can't just do MRIs in every 80-year-old patient. Otherwise, we'd be doing MRIs in every 80-year-old patient. So that's a problem. So I don't know what the answer is, but I think this is certainly an area
It's an issue.
of research.
It's an important issue. So before we close this chapter of symptomatic, we have the issue of rate and rhythm control. I'd just like to quote the data about how many patients undergoing ablation of paroxysmal atrial fibrillation at 5 years are still in normal sinus rhythm. And the data is 60% are on sinus rhythm, 40% are not, just to be aware of that. If the patient has persistent atrial fibrillation, this is the data across the board. If the patient has persistent atrial fibrillation in normal sinus rhythm at 5 years after ablation is 30%. So although we talk about, and maybe Vivek, you have a comment, although we talk about what we do with our patients, if we really look at long term, it's better we prepare our patients into what is in the corner, because otherwise I think we make a mistake. I like your comments.
Well, there's being in sinus rhythm and being in sinus rhythm. And what I mean by that is, if you look at most of the studies that we do, and we beat ourselves up quite a bit, I think, about trying to get good outcomes, we have a pretty high threshold for success. I mean, we want to have no episode of Afib that lasts longer than 30 seconds. Otherwise, we call it a failure. So a patient who had an AF, let's say the patient has whatever, weekly, monthly, even by whatever frequency of AFib, and then let's say we do an AF ablation, then 2.5 years later, they have a 5-minute episode of Afib, we call that a failure. Now, having said, I mean, imagine as a correlate, let's say, for example, after we did an angioplasty, anytime a patient has a 10% increase in narrowing, we would call that a failure. That's ridiculous, right? So, what I'm trying to say is the success rate is not where we want it to be. We want it to be 100% forever. But having said that, 60% in 5 years where failure is defined like this is not bad, actually. So stop beating us up about it.
Very good. Very
I
good.
find some of them are much easier to treat with antiarrhythmics than they were before, too. So, and that's not a total failure either.
We are seeing patients that are coming 5 years later with atrial fibrillation. They are disappointed. And I think the question I'm bringing up is that when we see a patient, we do an ablation, we should be very careful into what we predict into that patient in the long term. Maybe we'll need another ablation, and that's fair to say, but this is the point in time.
Yeah, no, I mean, I think proper counseling of the patient in terms of expectation, I think it's critical. Using the word cure is very dangerous when it comes to AFib.
Stephen, it seems to me that in this whole field, before we go to the end, which is prevention, and Jeff Mechanic is very anxious to speak. But the question I have is, it seems to me the better understanding of the mechanisms is going to be critical here, isn't it?
I agree. I don't think that, I agree, that's what we're working on. I don't think that one model will tell us the answer. It's a lot more complicated in humans. There are many roads to atrial fibrillation, but by understanding each possible road, you understand new potential targets, and I think that that's important.
There's an issue here, Stephen, and then I go into Jeff Mechanic, yeah, we should understand the mechanism, but it's interesting, what is the cause of death in patients with atrial fibrillation? And it's fascinating that 65% has nothing to do with atrial fibrillation. It has to do with the comorbidities that are associated with atrial fibrillation. And only 10% die of a stroke or something related to the atrial fibrillation. What we are really trying to get now is into a different approach or discussion, and that is, what are these comorbidities? What are the cause or consequence, and how can we avoid them? So it's also part of the mechanisms that we are talking about, I believe.
Absolutely. I think that having hypertension, obesity, they're all driving the same mechanism for developing atrial abnormalities, atrial enlargement, ion channel remodeling, and that's going to lead to ultimately to the risk of having atrial fibrillation.
So, Jeff, I have reviewed in detail 4 different types of comorbidities that, which the results or the data is conflicting. I don't think it is, but I'd like to know your opinion. I'm going to be talking about alcohol, number 1. We will talk about obesity, number 2. We will talk about the issue of hypertension, number 3, and then there may be some others that perhaps are sleep apnea and so forth. But let's begin with alcohol. And it's interesting because I asked for 2 papers in JACC to be state-of-the-art. And it's fascinating. In the paper that talks, alcohol has nothing to do with atrial fibrillation, except if you drink too much on a Saturday or a Sunday. On Monday, you might have atrial fibrillation, but that's it. In fact, it's in very young people aged 30, 35. So I think the question of alcohol, it becomes very, very obvious when you go into the adult population. It's a very important point, whether it's direct toxicity or affects some of the ions that Stephen is talking about, whatever it is. But what is your opinion?
So whenever you look at components of an eating pattern, you're in the field of nutritional epidemiology, and this is a highly flawed field. So for alcohol, there would be direct effects on cardiomyopathy if you wanted to go down that avenue. But more likely, what you're dealing with is an eating pattern that's unhealthy, and a lot of collider stratification when you look at epidemiologic studies where there are multiple things that are classifiers that you're then looking at an endpoint. So it's not the alcohol, but it's the fact that people who drink alcohol tend to have less of a plant-based diet, tend to have more of an unhealthy eating pattern, tend to have more of an unhealthy lifestyle. So there's that indirect effect. So the answer is there are some direct effects of binging, direct effects of oxidative injury, but more likely, from a statistical standpoint, it's the indirect effects on lifestyle and eating patterns.
I'd like to ask you about obesity. The data about obesity is very straightforward, except 2 recent papers that question. It's very straightforward in terms of obesity, perhaps through epicardial monocytes and macrophages and cytokines may lead to the injury of the atrium, and the data in the literature tends to sustain or support that obesity is very important, and even further, treatment of obesity and bariatric surgery, 2 recent papers actually on bariatric surgery, very helpful in the prevention of atrial fibrillation once the weight goes down. This is a positive aspect. You are in agreement with that?
Well, I'm not in agreement that bariatric surgery should be targeted as a treatment of choice. I think it's an incidental finding that those undergoing bariatric surgery had resolution or improvement in atrial fibrillation. Turns out that you probably need between 10 and 15% loss of weight in order to realize the benefits of weight loss on atrial fibrillation. 7% from look ahead is probably not enough. Over 10 to 15% from some of the studies is probably a minimum. And those are around the thresholds that you need for amelioration of NASH, NAFLD, and sleep apnea. It's about 10 to 15%. But I think the important point here is that a sign, a pathologic sign, or something that we're all treating, which is atrial fibrillation, really needs to be contextualized in terms of the pathophysiologic state. When it's occurring in the obese state, it's probably a different disease. So no doubt that with obesity and insulin resistance, and as a result of ectopic fat, pericardial, epicardial fat, and then as a result of that, oxidative injury, inflammation, the atrial fibrotic changes, the micro-reentrant circuitry that you see, you have a nice linear pathway that you can then probe, interrogate, and then target with interventions. And then you have your lifestyle interventions, which are probably the most potent. And then we have some medications.
Laurie, it has been said recently that if you do a CT and you look at the appendix physiology and kinetics, and you look at the epicardium in terms of fat, you are close to 50% of predicting who is going to be in trouble. Is this coming then?
So there are actually a couple trials looking at that, looking at the epicardial fat because it goes posterior around the pulmonary veins, and they think that the fat at a certain density starts to infiltrate and make these fibrotic changes and bring on inflammation and things like that. So there has been correlation between CT scans and looking at the left atrium and left atrial appendage and fat.
Okay. This is a question about hypertension, and hypertension is complex, can cause a stroke by itself through atrial fibrillation, can cause bleeding as, related to stroke and so forth. I passed this, but I'd like to finish with the issue of diabetes, which is quite interesting. It has been a question of whether diabetes that is not on insulin may cause atrial fibrillation, but there is no question that those who are on insulin, they cause it. And the answer has been that those on insulin is much more severe diabetes with all the consequences. Is this correct, Jeff?
Yes, and it's unclear, though, what the mediator is. One might be glycemic variability, where you're going from hypo to hyperglycemia as a result of a drug that's very potent in lowering blood sugar. And then, of course, the insulin molecule itself has direct actions in the myocardium. It affects the reperfusion injury salvage kinase pathway. It affects a lot of other molecular trafficking pathways as well.
Stephen, I have a final question. You have two approaches here on atrial fibrillation. First, there are so many people who has it. Actually, it is silent in 40% of people. So my question is, one is to go into the mechanisms, and the mechanisms are the basic molecular mechanisms, ions, fibrosis that we talk about, or the gross mechanisms of the world of consumption that we live. But what about screening everybody for atrial fibrillation? And if it is, how it could be done? To start things earlier, that's what I'm saying.
Well, it's tough. I mean, I think that clearly improving cardiovascular risk factors in all our patients is probably one of the most important things to reduce the risk of atrial fibrillation. And even those patients that do have atrial fibrillation, reducing their cardiovascular risk factors and exercise is important to reduce the incidence of atrial fibrillation, and even after ablations, for instance. Obviously, too much exercise probably is not good. You don't want to be a marathon runner, but some exercise is good in these patients. I think that there are newer technologies that are coming out. Many of us have iPhone-related ECG monitors that patients have used to detect atrial fibrillation. There's been recent studies using those showing that they can, it's a better approach to detect atrial fibrillation in patients.
You like devices,
Alive
Vivek,
core.
do you have anything in mind?
Well, Alive Core is one of them that people have used effectively in patients to detect atrial fibrillation.
Yeah, I mean, I think that I'm particularly interested in the smartphone type technologies because everybody has them anyway. So I can see how that could be very useful. I'm less excited about anything that requires an additional purchase because I don't see the cost effectiveness in this. But the last point I just wanted to make was, overall, I'm very optimistic about trying to catch it early because I think that getting somebody to modify behavior, as you've stated before, is very difficult. It's one of the most difficult things to do, trying to tell somebody to lose weight for a future potential benefit. But if you show that person they're having something early, that they're catching early and they're having AFib, and we have something that an approach to improve this, which is exercise and weight loss and all that, then I think you have a chance that you can actually modify behavior in a subset of those patients.
Yeah, it's to detect early and to educate early.
Right.
That's basically, and so many things in the cardiovascular field. Questions, comments? Yeah.
I'm interested to know if you have any thoughts on the relationship between uric acid and AFib. And now the new studies on colchicine.
Be short. If you say no, you don't know, say no.
So there is epidemiologic associations. There are studies with colchicine. There's immediate inference that uric acid plays a role. There's also uric acid epidemiologic associations with atherosclerosis, coronary artery disease, vascular disease, vascular inflammation. Beyond that, there are some more esoteric intermediary metabolism pathways, but I wasn't really impressed in my reading of it that it's going to be a strong target. I think that if you're moving in your algorithm to pharmacotherapy for AFib from targeting a metabolic basis, and you've already exhausted your lifestyle medicine opportunities, then you're moving into considering a TZD, considering metformin, considering a GLP-1 receptor agonist, statins for the anti-inflammatory activity, and then some dietary approaches that could use some supplements for antioxidants. I would do all of that probably before I would consider colchicine.
Other comments? Yeah, Doctor.
Thank you very much for a very complex, involving, visualized treatment. Maybe that I do, but with the benefit of having Dr. Paul Stelzer in the audience, the thoughts about atrial appendage closure as a routine operative.
Paul, can you answer the question?
Thank you, Ronnie. I was thinking of that too, and I was just reading an article literally before I came over here about a presentation at the European College of Cardiology meeting, the LAACS, the LAX trial, which was a randomized trial of ligating or not ligating the atrial appendage, and it came out in favor of ligating the appendage. I must say it wasn't a very impressive way to do it, but they literally ruled out cutting it off and sewing it up, which is what I do. I guess they're just wimps. I mean, they're afraid of bleeding. Well, come on, that's the way to read it. And they actually only did TEEs on 10 patients and said that they were all closed completely. I mean, that's the limitation of closure devices and closure techniques, whether it be by transpericardial approach or in the operating approach. If you're going to close the appendage, you want to make sure you get it all closed. And the best way I know of doing that is making it be gone. And then you got to make sure it's all gone. And then there's the question, that even there, just as you said, if the Watchman device doesn't get completely endothelialized, does the suture line that we leave behind in any surgical incision in the left atrium completely endothelialize, and what's the time course of that? We've learned that just doing cryoablations and so forth are not completely innocent, that anticoagulating those patients for at least a month or so after is probably appropriate. And I think that's something we learned the hard way, right? That everything we do to the heart is not a free lunch in the operating room or otherwise. But I think there's going to be a lot more opportunistic removal or closure of left atrial appendages now that we see some data evolving that that's going to be beneficial, maybe from both a rhythm standpoint and from a stroke control standpoint.
Okay, thanks. Any final question? Yeah.
What's striking about this presentation this evening is the demographic imperative and the age-related phenomenon, but the lack of where's the investigation into the physiological changes that occur with aging that that there's a correlate here. I mean, it's an underlying theme, but nobody seems to address it. Am I to assume that fibrotic atrial cardiomyopathy is a cardiomyopathy of aging?
Well, what you're saying is aging is critical, and that's why the atrial fibrillation epidemic is evolving, because people live longer and the risk factors are there. And I think that's is a critical issue. And actually, all what we discussed today is problematic because you are using anticoagulants and a number of drugs in the elderly population, which is much more difficult. So.
I'm suggesting that there's something underlying in the physiology of normal aging that may have some impact upon atrial fibrillation.
That the reversibility, the extent of reversibility with weight loss would argue against that. So if there was a dominant driver that was part of a degenerative aging process, one would not expect that losing weight to the extent of 10, 15% would have such a magnitude of a response. That's not to say that there aren't cases that are degenerative that aren't due to aging, but I think for the purpose of conversation, right now we can't discriminate between an aging and a non-aging type. So that's why the pragmatic recommendation is the lifestyle, the interventions, and all the technology.
Vivek, you have a comment?
Actually, I just want to ask my quick question. Jeff, if you said in your comments that you think you need about 10 to 15% weight loss to have a real appreciable effect. Now, as you know, in some of the electrophysiology literature, there's the Legacy Registry and the CardioFit Registry, which is basically the same thing. But anyway, they're relatively large registries, and in their registry, even intermediate weight loss did appear to have some appreciable effect. I'm talking about intermediate being whatever, 2 to 8% or something like that. And the 8 to 10% or higher was the high weight loss, which seemed to have a more dramatic effect. Now, none of this was randomized, and I understand the limitations, but you're not swayed by that data? How do you interpret that? I guess what I'm asking is, where do you get the 10 to 15 as opposed to, I don't know, 5 to 10, for example?
So the 10 to 15 is just taking the weight of evidence and retrospectively looking post hoc at a lot of the studies that have looked at weight loss where you had entry criteria or entry statistics for atrial fibrillation and looking at a decrease after the study period or with extension studies. However, I really would qualify by saying BMI and the term obesity as defined now by BMI serves us very poorly. So all the comments about BMI and obesity really need to be tempered and dampened. This is just an awful classifier to look at this disease. This is the reason why recently we've redefined this as an adiposity-based chronic disease, where it's not just in terms of BMI, but rather also in terms of adipose distribution, which includes ectopic adipose tissue, which is best diagnosed with imaging, and also abnormalities in the adipocyte secretome. For instance, hyperleptinemia, which you probably studied in your murine models, is another risk factor, and it amplifies the atrial fibrillation effect. So when you have adipocytes, even if your BMI is normal and even if your waist circumference is normal, but you're overproducing leptin, and because you have a leptin-resistant state, that person or experimental animal is at higher risk. So when you look at these studies retrospectively, because they weren't designed for this, that's why you see this.
Yeah,
this,
we should cut. Very basically, the paradoxical issue of obesity is that if you have a high BMI, it may be all muscle and not necessarily is fat, and this makes a hell of a difference. And this happens in the atrial fibrillation. Most of the studies that show that obesity is important is central obesity, because it's most of the obesity is most related to fat. Stephen, I want to ask you a final comment you can make of everything we have discussed today, other than the field that you are working. Where do you think is a challenge, or that you feel excited that you learn, or that you would like to get into it?
Unexpected question, I have to say. We're working on many other areas in the heart as well, as far as contractility is concerned, arrhythmogenesis, adrenergically mediated arrhythmogenesis, which is, I think, an important problem. Afib is just one of the areas that we're interested in.
Thank you. Thank you very much to all of you. Thanks.